This is a treatment plan for a full upper reconstruction. We're planning to put 5 implants on the maxilla. Patient already has 3-unit bridge on 2, 3, 4, and has a single unit on the number 15. So it would be recommended to extract tooth number 4 and place an implant in 3, and then proceed and do the tripodization to maximize the implants, so that in the future, if the patient loses the 2 molars that are left behind, there will be no need to place any more implants or replace the framework and the teeth that will be reconstructed for her. So we are planning for failure up front, so we can move forward and place enough implants now so that in the future patient doesn't have to go through another procedure to get more implants done. So 2 implants will be placed on 8 and 9. That's where the bone is, and this is showing tooth number 8 right now, the animation, and that's where the maximum bone is. And then we're going to place one on tooth number 13, 14 area there to get the maximum AP spread, so that if need be and the patient decides to extract these molars, we can do a cantilever there with enough implants in the front to support the AP spread that we need. Here now, this shows the DICOM data of the patient that was rendered with our software, the Implanto implant. The mesh was cleaned up. There was quite a bit of scatter involved in the process, and of course with that much scatter you will not be able to render images or merge the data. This shows the sagittal slice. As we move the sagittal slice from patient's right to left, we could see that there's a very thin area in tooth number 10, tooth number 11, and tooth number 12 area, and that's the blue that you see there in the sagittal view as the cursor is moving from left to right. We color it so you can visualize where the dense amount of bone is. That shows the deep blue that is in there, and of course that's all the scatter that we are looking at right there. Then we take the patient scan, and we take the surface scan from the impressions, which in this case they're polyvinyl, or the intraoral scanner. But again, the fault here is the impressions were taken with a gun injectable putty, that when you seed it, the putty will touch the teeth, the teeth will touch the tray, I should say. And when that happens, it's very difficult to segment and separate the teeth from the tray, and as a result this becomes very difficult to make it watertight. So the impressions have to be made with putty, polyvinyl siloxane putty, and not polyether, and they should not touch the tray when they are seated. Now when you take the DICOM data of the patient and you take the DICOM data of the surface scan from the impression, which is on the right side as I'm rotating it, as you can see, then you need points to merge the 2 data together. Then you need points from the patient scan and from the impression scan, and then when you select these points and you merge them, then you can merge these 2 sets. It's impossible to fabricate a surgical guide from the patient scan only. That's why you need the surface scan from the impression in order to merge the data and make the surgical guide. Here we have reverse engineered the teeth from tooth number 5, 6, 7, 8, 9, 10, 11, 12, 13, and here I'm going to start by showing the placement of the implant on tooth number 3 position first, all the way to tooth number 13 on the other side. So I'm going to recommend extraction of the 3-4 area there, leave the molar number 2, and we're going to place an implant on tooth number 3 to maximize the AP spread. We're going to angle the implant so we don't have to do any sinus grafting. It'll be a graftless technique, and this implant will be a 4.3 by 13 millimeter. So it'll be an immediate extraction, immediate placement during the surgery here. And this implant will be away from the sinus, and it should be have enough 1/3 of the implant in native bone, as you can see there, to anchor it. Then we're going to place an implant in tooth number 5 position, because number 6 is very thin and there is not enough bone. And as I zoom in on the number 5 there, we should be able to place a 3.5 by 13 millimeter implant, and this will notice the safety zone, which is the two black lines around. It shows that there's not enough bone. So use of the osteotomes in this case would be ideal. Number 8 will be the next position for the implant because that's where the bone is. And same thing, we're going to use a narrow platform, 3.5 by 13. Again, the safety zone shows not enough implants, so you can use a 2mm drill, expand the socket with the osteotome, and place the next implant. Number 9 is going to be the next anterior position for the implants. It'll also be a 3.5 by 13. There's plenty of bone in number 9 width-wise, as you can see, buccal lingual. And if you look at the safety zone, the two black lines around, there, it looks like there's sufficient bone here. You don't need to use the osteotome to expand the site. Of course, the last implant, again, this shows it, and the last implant has to maximize the AP spread. It's going to be around tooth number 13 area, and it'll be a 3.5 by 13. Ideally, I'd like to put a 3.5 by 16 if you don't mind placing longer implants. I prefer to anchor them to the subnasal plate and get better anchorage. Here in this case, you see we have 5 implants, so because we will not be able to place implants in number 11, as you can see, very, very thin ridge in there. It's practically impossible to place an implant there without major facial augmentation of the bone. Number 12, same thing, very, very thin lip of bone in there. There's no way to place an implant on 11 and 12 area. And as well, there's no way to place an implant on tooth number 10 as well. And so 10, 11, 12, very difficult to place implants. So we have to maximize the AP spread between number 9 and number 13. Ideally, I would have liked to place 3 implants on the right, 3 implants on the left. But in this case, we're going to have to go with 5 implants unless you decide to sacrifice the molars as well. And then you can do a single time reconstruction. Again, here it shows the animation of the implants as they're placed with a 360-degree view of the bone surrounding the implants there. And you can see the tracing of the dense bone that's in there. And it'll show the animation from one implant to the other as we go from tooth number 3 to tooth number 5, then tooth number 8, and show the AP spread in there. This is number 8 as I show right now. Again, there's plenty of bone on number 8, maybe a little bit of augmentation on the buccal plate there to make sure we have enough bone as you load anteriorly. Then number 9 is going to go in, plenty of room on number 9. We chose number 9 because it's good. And then of course the last implant is the number 13 implant in this case. This should conclude the treatment plan for this full upper reconstruction.